Hello, welcome all. My name is Alan Barr. I'm with COEH Northern California, and on behalf of the NIOSH-supported education and research centers throughout the country, we're pleased to present the 2022 ERC Ergonomics webinar series, where we offer free monthly webinars on various topics on human factors and ergonomics. This collaborative effort on behalf of each ERC's continuing education program aspires to provide access to current research supported through NIOSH ERC programs. Thank you very much for joining us today. All participants who logged in today with their registration email will receive a link to an evaluation form that will qualify you for a certificate of completion worth one continuing education contact hour. On the 30th of this month, Dr. Carissa Harris will be presenting Home Office Ergonomics Post-COVID-19, Carpe Diem. I encourage you to check that one out. You may register for that and other upcoming webinars at coeh.berkeley.edu/webinars. For today's webinar, you will be muted during the presentation. If you'd like to ask a question, please enter it into the online Q&A, and we will have some time at the end of the presentation to address your questions. Today's webinar is being recorded and will be made available along with past webinars on the COEH Northern California YouTube channel. Please take a moment to like and subscribe to help us continue to grow that channel. Today's talk is titled Health Disparities in Meat Packing. Our speaker today is Dr. Kermit Davis. Dr. Davis is a professor at the University of Cincinnati, where he is the graduate program director of the Environmental and Occupational Hygiene and Occupational Safety and Ergonomics programs at the University of Cincinnati. Dr. Davis is a past president of the Human Factors and Ergonomics Society and a fellow of FHFES and American Industrial Hygiene Association. His research has concentrated on reducing ergonomic stressors of healthcare workers and patients in a variety of healthcare settings. In the last year, his research has focused on virtual offices. And with that introduction, it's my pleasure to hand the mic over to Dr. Davis. Welcome, Dr. Davis.
Yes, thank you. I will be talking about a project that I've been working with NIOSH through their intergovernmental personal agreement, IPAs, for the last 2 years. If anybody's done a review article, you kind of understand that these things kind of grow and kind of take a long periods of time, at least what I've had. So this is work that's been going on for about a year and a half, I think, and this kind of summarizes what we found during this review process. If you look at the meat processing industry, you really have various types, but it's dominated by processing of beef, poultry, and pork. But there are other meats and other processing plants that are out there. I will not be talking about seafood and that type of processing. This will concentrate mainly on beef, poultry, and pork. If you look in the United States, there's over 500,000 workers in this industry that continues to supply meat for multitude of customers, both at the restaurant level, at the grocery level, and at the personal level. And so these are workers that are upstream from the grocery and the restaurant level. This is looking at large processing facilities and looking at the exposures to them. And if you know anything about these processing facilities, there's a very diverse level of exposures. Oftentimes there's a lot of awkward postures, high muscle exertion levels that are required to cut the meat products up. And in order to keep the meat products from spoiling, you have to have it in a cold environment. And then finally, there's high repetition. So, this is a very unique work environment, and often one that has high levels of musculoskeletal disorders. If The other unique thing about this was these were essential workers during the pandemic. And so some of the research that we looked at resulted from exposures to COVID-19, and looked at some of the issues revolving around that, being essential workers, being required to work to produce the food sources to the United States, particularly. One of the things with all the exposures you see up there, there are high levels of musculoskeletal disorders, but there are also other health outcomes that these individuals have been found to encounter. There are higher rates of cancers, respiratory diseases, and other exposures that have led to other health outcomes. And so you're looking at a large workforce, a large industry that is essential and that has many different exposures and a lot of health outcomes that are detrimental to them. And what I did, or what we did in this review, is to kind of look at some of the underlying factors that could exacerbate these exposures. So one of the things that you can look out in literature, there are many different types of identified health disparities. One of the primary ones is gender or sex, and that relates to a lot of issues dealing with socioeconomic concerns. That can range from the need for daycare, being single mother. Oftentimes, females are underpaid in this industry. And it does allow to, some of these concerns of how actual injuries and illnesses exacerbate over time. Another key component for this industry for females, and I'll also talk a little bit with the minorities also have been found, is the job insecurity. There's a lot of turnover a lot of times and being let go. That they worry about, and especially if you're a single mother, that job insecurity drives a lot of your decisions of when you get to seek treatment, when to report an injury, and can really undermine a lot of issues revolving around health. Also, some researchers have shown in certain industries there's less safety training, that these individuals can then be exposed to, not knowing what they're getting themselves into and having proper training. The next one is minorities and ethnicity. So race and ethnicity. Again, in many cases, there's a socioeconomic undertone of this, of lower wages, which also leads to job insecurity, worrying about being fired or having retribution if you're reporting injuries, has been found in industry or found in research. And oftentimes that leads to being exposed to riskier jobs with less safety resources. So many times it's also been shown in the literature that individuals don't have the same proper, protective equipment, PPE to potentially protect them. For examples, for both of these, for gender and minorities, examples of this would be, not having proper guards when cutting, using knives and cutting, into the animals as they dissect them and resect to get the various components of the meat. And what happens here is again, it's a combination of worrying about their jobs and not wanting to report an injury, especially injuries when they're at the where most ergonomists want to be in the minor stage of discomfort. So oftentimes when they do report, it's in a much more traumatic and in a extended type of injury. So more of a surgical repair or a time off type of injury. Similarly, immigrants are also oftentimes hired in this industry, and oftentimes this is a higher level of worry of being deported. Again, job insecurity is a consideration. Again, these are individuals that don't receive the proper safety training or PPE. And as you're seeing, you're starting to see various types of themes that are going through here. And this all leads again to fear of reporting the minor injuries, and oftentimes can lead to the more dramatic type of injuries. Then the next one is education and literacy, and certainly lower education, not being able to understand English. You know, many of these individuals and that are being employed have you know, other non-English languages as their number one. What I just lost it. Their number one language that they speak, their native language. That's what I was looking for. And they also have been some reporting of being bullied by supervisors, and oftentimes giving their education levels and literacy can fall into the traps of being bullied by their supervisors. And this again was reported by the literature that's out there, not necessarily in the literature of meatpacking. And so class is the final one. Again, limited socioeconomic level is a huge issue with class dealing with you know, the funds that they're able to occur or incur, and that this also has been out there as a health disparities. So as I was saying, there's some common themes with health disparities, and that can be found in all industries, and all types of health outcomes. And what we'll be looking for here is how does this specifically relate for the meatpacking industry. But some of the common themes that you saw previously were low socioeconomics, oftentimes, you know, low wage earners, that really impact on how they are going to respond to both their safety reporting, and concerns about their day-to-day work life. They're also a lot of times limited in training and resources, so the PPE oftentimes, you know, the limitation, you know, during COVID was less, you know, not having the proper you know, face masks was a big issue. Limited access to healthcare providers is also, you know, a common theme. And you know, with all of these, with jobs insecurity and all these limited training in social economics and access, leads to, you know, really a feeling of lack of support from the company. And all these, you know, really undermine the reporting and the treatment of injuries, particularly musculoskeletal disorders. And again, this was what was found in many other industries. And what this review was trying to do is to go sort of a deep dive into what is being looked at in the literature for meatpacking. And that leads to the objective was to investigate whether gender, race and ethnicity, education and language illiteracy, and class influenced health outcomes in the meatpacking industry. And so we started this in looking into, you know, are there people looking and researching health disparities that have commonly been found out in other industries and other literature, and see if it actually was being targeted in one of our, you know, essential working populations, the meatpacking processing industry. Next, I'm going to talk about sort of our methods for this review. First off, we started off looking at health outcomes of musculoskeletal disorders. And what we found and what you'll see is we didn't find quite as many articles as we thought we would find with respect to these areas that I just outlined. So we expanded it to other health outcomes, particularly COVID-19 and cancers. And we looked at articles that were published prior to January 2022 in English peer-reviewed journals. The primary search, which I have found with reviews, is probably one of the best, is Google Scholar, because you pretty much get anything and everything that's under the sun that's out there published, and even non peer-reviewed journals are on it, and you kind of sift through all them. We use the keywords meat processing, poultry, pork, beef, health disparities, musculoskeletal disorders, COVID-19, cancer, and health outcomes, and looked at all different combinations of this. What I did was, started with 1 and 2 and 3 words put together, looked at all different combinations until I started getting a queue of abstracts and titles that were not getting any different from what I had. And I'll talk about sort of the search parameters and how we whittled it down from that point. We did rank each article based on the level of evaluation for each health disparities, and this will be the main results. It started with just a level of, did they report any breakdowns, demographics reporting of the data of gender, of race, ethnicity, class, education, and all those, that just did they report it as part of their results. The next step was to look at, also looking at whether they tested for significance, not whether they found significance, but whether they tested. And then the final level of it was looking at the level of significance, that whether they found a significant effect for each one of those. And then, the other sort of unwritten part of this was to look at, did they actually discuss health disparities that could undermine each of these areas, and what are the factors, and did they evaluate them? And I'll talk, the last part of the presentation, we'll talk about that, where we're, what we found on that. So if you look at the search results, our initial use of keywords was over 26,000 articles, looking at all those different combinations. And what we found was a broad type of ones that I started going through and reviewing the titles and abstracts, whether they were relevant or not. And I got that down to 120 selected articles that were based on the abstracts and review titles. So as I said, it took over 1.5 years. This took a long time. A lot of times a lot of them were ruled out. I didn't go and review all 26,000 by any means, but I did do several thousand abstracts that I actually read and went through in detail. And then once I looked into the inclusion and looked at the individual articles to see if they really were relevant, not just based on the abstracts, we did a deeper dive on inclusion, and then we quantified certain things like country, study design, key results, and also looked into the reference lists for additional articles to continually to build, which did result in probably 10 to 15 additional articles that were not covered in the search originally, and we just kept building out from those, particularly the more recent ones, and that. So in the end, we ended up with 60 articles included in the review, and we'll be talking about the results in a few minutes about them. So we had two studies that looked into beef processing. We had 28 poultry processing research studies. We had 4 pork processing studies, and then we had 26 general ones where they didn't specify whether it was pork, poultry, or beef, or it was a combination of 1 or 2 or 3 of these. So those were classified into one type of facility in general. We also looked at the countries that were represented, and it was dominated certainly by the United States and North America, with 34 studies in the United States and 2 in Canada. It was also had significant ones in Europe with Croatia, Denmark, Finland, France, Italy, Sweden, and Netherlands all represented. We also had some South America ones, which was dominated with Brazil with 6 and Venezuela with 2. And then Asia and Australia, there was just a few with Australia, South Korea, and New Zealand in that area. And so, these were what was represented in the literature that we found, and just kind of represents across the world when we're looking at these individual outcomes. So if you look at musculoskeletal disorders, as you see, we did have a significant number of them. Many studies or 13 of the studies did look at gender of just reporting. Another 13 looked at statistical tests, and then another 8 looked at and found a significant difference between males and females. So there was an underlying, investigation of gender differences. And then, Les had looked at race and ethnicity. And I would say in this case, many of these were broken down into, sometimes they would be focused on a certain population. And so there wasn't necessarily a breakdown between race and ethnicity. But there's 7 that just looked at reporting it, the difference, another 2 that did a statistical test, and then another 3 that actually found significance. And so what you're seeing here is some are evaluating it just by reporting it, and some are doing tests that didn't find significance, and then some found some significance difference. And then similarly with language, literacy, and education, 10 just reported it, and then you had 3 that both tested statistically and tested and found significance, 3 also. And not many studies actually looked at class, and when dealing with class is dealing with the poverty and some of the underlying economic issues with class, but not many studies actually looked into those, less than 4 total. And nativity and immigration was an issue, or was reported, and about 5 studies looking at reporting and statistical tests in one, and actual finding differences in one statistically. So this was what the picture for musculoskeletal disorders, and this is why we sort of branched out to see if there was other health outcomes that you might have some different type of investigation. But I will say with this literature, and what I'll rehash in a little bit later and discuss, is that none of these really dove into the factors that we talked about previously. At best, they were just reporting and maybe looking at some statistical differences. Figure out it. Hold on, I'm trying to figure out how to hide my little I believe this is, my title is above, so I can't see what the title is. That's the problem.
The title of the slide says cancer.
Okay, sorry. Thank you for that. The bar above has got all the controls. It's not hiding, so I'm not sure. But what we found with cancer was there was only a few studies that were really looking into this, so 4 studies that looked at the gender, just reporting it, but there was 4 additional studies that also identified statistical significance between males and females. Similarly with race and ethnicity, 4 just reported and 4 statistical significance. So there's not a lot of studies that are out there in the various cancers. A lot of the cancers that were being dealt with were respiratory, dealing with just the animal residues and stuff like that long-term exposures to them, as well as cleaning solutions and stuff that they were looking into. And so this just gives another contribution of not much really with understanding the underlying health disparities, other than just at the higher level. So this should be COVID-19. And basically what you saw across the board is they really just reported and didn't do any statistical significance in the studies. There were, again, about 3 to 4 total. And so many of these studies did, across the board, look at various things, but didn't really get into statistical relevance or even the underlying factors. Then the final one is general health outcomes. And as you see here, many of them with gender, there were some that looked at just reporting, but it was more looking at statistical significance and actually finding some statistical significance with these outcomes. And these outcomes could range from anywhere from warts to lacerations and other things that were not musculoskeletal disorders, but were other type of respiratory issues also. And then with the ethnicity and race, you had some that all of them were statistically tested, and you got some that didn't find significance and some that found statistical significance. And then there were very few that looked at language issues, class issues, and immigration issues. And so what you see in all of these is a common theme of, a lot of them trying to just report differences, and some of them are going to the level of looking at statistical differences, but then not really getting to the underlying factors. So there are many missed opportunities in this literature that we need to really get to start understanding, to really understand the health disparities and the impact of these health disparities. One of the things that you see is, it focuses on reporting the demographics a lot of times. And then some studies got to the next level of statistical testing. But there was no real investigation of actual health disparities and the underlying factors of why gender might be a factor, beyond just saying that there was a difference. Most studies equated it to just the exposures at the workplaces versus many of the health disparities issues that were out there: lack of resources, lack of insurance, lack of training, job insecurity, social economic issues. None of these studies really investigated any type of level of these. So what you have is this sort of potential, top of the pyramid where you're capturing, reporting and statistical analyses, but you're not actually getting to many of the underlying contributors that could exacerbate or cause individuals to end up having more detrimental injuries, leaving the workplace prematurely, and really not getting to why many of the issues that were statistically significant, that were what are the underlying causes in many senses. So the take-home message is many industries, have identified health disparities, and really looking at the underlying factors of why there's differences between genders, not just totally relating it to the exposures. There are many issues that contribute to the differences between genders. And we can't really understand, what those are unless you start measuring them. Similarly with the different races and different immigration levels, different class levels, all of them, have been identified as having health disparities, having issues that are not controlled, that can undermine people staying healthy in the workplace. And so we are just now needing to start to understand and develop the research to identify the disparities in meatpacking. And as you saw with many of the results, we were really talking that we're just getting the surface level of understanding of what some of these differences are, that these populations have such unique characteristics and unique underlying circumstances that could really exacerbate many of the health outcomes, and especially dealing with being a essential worker, not being able to capture some of these. We'll never get to the understanding of why they're working through pain, why are they getting to the point of not reporting, and oftentimes mistreated is the other aspect you see. And so really what we're seeing is a real missing of the underlying contributors to health disparities, in that we've now just sort of touched base at the high level, and we need to start digging deeper to really understand this working population and what is causing them to have significant injuries still. I'm not dismissing the workplace factors. They are certainly contributors, but there are so many other factors that I think can exacerbate what those factors are doing to these workers. And so we need to start designing our research studies to better identify underlying factors for health disparities in meatpacking, and specifically meatpacking. I mean, there are many researchers that are working in this area now that are starting to understand the complexity of these contributing factors, and that's when we're ultimately going to have towards more of the total worker health environment to protect these workers, not just in the facility, but also at home, and contributing on multiple levels. And with that, I want to say special thanks for support from NIOSH through the IPA work over the last couple of years. And I'd also like to recognize Jacqueline Savine and Greta Davis, that is working on this project also, and has gone and put, will be continuing to put together the review article and get it published, and hopefully challenge the researchers to start looking beyond just the high-end exposures and personal factors that could be contributing to the health and of these workers in this industry. And with that, I will accept any questions.
Thank you, Dr. Davis. We have the floor open for questions if you have any. I currently have no questions in the queue. I have one. I noticed I guess I'm wondering why the global approach. What did you learn by looking beyond North America or beyond the United States in your research?
One of the things I guess I learned that many of the countries are, approach the research the same way. They keep it at the high level. There wasn't a lot of differences in looking at these underlying health disparities. Even less in some of the other ones with immigration. A lot of the immigration type of studies were from United States, and so that that was one of the big factors I saw across the countries. But that's a great question. But I mean, you still have a lot of the same type of exposures and a lot of the same type of most of the time they were looking at gender differences. If you looked across other countries, there were some European ones that were doing differences in nativity and differences in races that was seen over there that you did have in the research. But some of the South American ones were more homogeneous, I guess, is what I would say.
Okay, great. Thank you. So Dr. Goldberg asks, he'd like you to comment on these factors, if you would. Union status, supervisory and management status, access to appropriate medical specialties, access to physicians of similar ethnic, racial background. Thank you.
I don't remember seeing any of those specifically that were talked about. I know, specifically there was nothing on X. There was some, most of the research that I came across wasn't looking at a lot of these factors, and I think that you're hitting that exactly what I was trying to get at is to that we need to get to a lot of these differential type of at the very lower levels and personal levels to get to understand how the different health outcomes are impacted. Union status I don't think was really brought up because most of the times if they went in, studies stayed in one facility, so if they were either unionized or not unionized. So I didn't look at across studies. That's a good thing. I might go back and look into for all of these. Access to physicians with similar backgrounds, I guarantee you that was not evaluated that I saw in any of them. They weren't focused on that. So that's, I guess, how I'd answer those. So.
Okay, thank you. Ken asks if there is sufficient demographic heterogeneity among meatpacking workers to make meaningful internal comparisons. If not, have you considered which other industries workers could make suitable comparison groups?
Great question. I think I would think, in many cases, there's a significant homogeneous part of it with the research, and it was about either regional or country that was, I think, that where you got the meaningful comparisons. And but I think I certainly probably could go back and dive in deeper with some of these comparisons. I mean, that's a great point. Suitable comparison groups, that's a really interesting one. Probably the most suitable would be construction, would be my guess on being able to compare to these, which would have some that are not as comparable, but some characteristics that are comparable. Certainly, there are times in the winter, in the cold climates, that you would be working in somewhere cold environments. But obviously, if in the construction in this, warm regions would not have that cold component. The other problem with construction is you've got so many different types of exposures, so it's not really as repetitive as the one. But there are high levels of low wage earners, immigrants, and various nativity and races that you would have in construction. So that would, in that sense, I think with some of the health disparities, it would be a comparable group. But I don't know if it's a total perfect comparison. I don't know if there's any perfect comparison to the meatpacking workers that I've seen.
Got you. I noticed in your sampling that was very poultry heavy. We had 28 chicken processing plants. Is that because there are more of them, or is that just a hot topic or focus of interest?
Well, that's a great question. If there's more, I'd have to go back and look and see if there's more facilities. I can get an answer for that one. I don't know that one for sure. I think it's certainly one that has gained over the years a focus for research because of the high levels of injuries, special musculoskeletal disorders, and so I think that is certainly one that one of the reasons I think that they're so highly investigated. And I think that the other thing is I think I'd just be hypothesizing at this point of why that is. But it does seem like it was across the board. I will say, in other countries, one of the things that it seemed like in the United States, it was, you had a separation between the meat products, where in other countries, it seemed like they overlapped. Like that's where you got the general type of ones where you had multiple species in a one facility. So that's where I think you could see some of the other ones. But that I would have to go back and look and see if the actual numbers are different in actual number of facilities.
Thank you. Steve comments that he's seen all of these issues in red meat, poultry, and onshore as well as offshore fish processing industries, and he's just glad to see your presentation. And then Michelle asks, what do you consider next steps for your research? In your review, did you come across any topics you or one of your students plan to get more data on?
That's a great question. At this point, yeah, I sometimes I go in so many different directions that I don't know if my research is going to take me into solving some of these problems on a research side of things. That doesn't mean it won't, but this just was an opportunity that I wonder if there's some focus in NIOSH that seems to be, especially with the offshore seafood processing. They have significant efforts in this area too, and that's how I got sort of into this review article during this whole process of this. I will say, one of the things that I will be looking for, maybe not in this industry, but certainly to help. This has opened my eyes to health disparities. And our Education Research Center is doing a lot of work in home health care, and I do see an industry there that has some of the similar type of lack of resources and dominated more of females. that has, some issues that with I think health disparities that I will carry in the research into that area for sure. I see this is something that will gain traction in my research, probably within the healthcare systems and stuff. So, and particularly with home healthcare. But I'm not sure I'll be. I mean, I do work with consulting with some processing, chicken poultry processing. But I'm not sure I will dive into the meat processing and research, but you never know. So,
Okay, well, thank you so much for taking the time to present that talk to us today. Do you have any closing comments before I sign us off for the day?
I don't think so. I just think the closing comments is, there are many factors with health disparities in many industries, and we really need to start taking consideration. This was just one example of one industry, but there are many factors that go beyond just the actual stressors that can relate to severity and the number of injuries in the workplace.
Excellent, thank you. You can learn more and register for our upcoming events at coeh.berkeley.edu. You can also subscribe to our YouTube channel where you can find recordings of previous webinars, as well as this one. As a reminder, if you logged in today with your registration email, you will get a link to an evaluation form that will qualify you for a certificate of completion worth 1 continuing education contact hour. If you have any questions for us here at COEH Northern California, you can drop us a line at coehce@berkeley.edu. That's coehce@berkeley.edu. A big thank you to our presenter today, and thank you all for joining. See you next time. Bye-bye.